Ladies and gentlemen, you are about to witness one of the most anticipated evidence-based medicine battles of the day. Are you ready? Our first fighter from the great white north. He'll hit you
Where's
hard
the music?
with evidence-based medicine
The Rocky music.
knowledge.
Yeah.
And they don't give you a nice Canadian apology.
Yeah.
He may not be coming, but he's also known as Bat Dog Ken, the Skeptic Mill. His challenger from deep in the heart of Texas, officially the center of the FOAMed universe, unofficially the sexiest man in FOAMed, it's Salim the Rebel Reside! Never got a slide there. Now, gentlemen, this is an EBM brawl, Ken, none of that hockey brawling stuff. Evidence-based medicine means you're going to consider the best available literature, but also clinical expertise and patient value. There will be no logical fallacies. Keep it above the belt. Nobody here wants to hear about the size of your p-values. Let's keep it clean. All right, gentlemen, round number one, man versus machine. Should we be using mechanical CPR?
Go to our corners.
Skeptics! 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 Woo! Come on, man.
It's kind of sad that he has to bribe all these students to cheer for him. Kind of sounds like somebody's conceding the fight already.
I'm so looking forward to this. All right, so we're starting?
Let's do it.
Okay, let's do it. All right, so we're starting with mechanical CPR, and we're going to have 4 4-minute rounds roughly. And the first one, I think it's going to be a really easy round to come out punching hard, because we're talking about mechanical CPR. And when it comes to mechanical CPR, there have been multiple, and I mean multiple, industry-sponsored trials looking at mechanical CPR. And guess what they found, audience? No superiority. So what did they do? They took these biased studies and combined them into a systematic review and meta-analysis, and guess what they found, everybody? No superiority. For a patient-oriented outcome, Sal, we call that a poo. A poo, Sal. Okay, no patient-oriented outcome. And yet they want to put one of these mechanical CPR devices into every one of our trucks to help save lives, even though we don't have evidence that it saves lives. If you don't have a shockable rhythm as your initial rhythm, your chance of survival is about 10%. If you don't have a shockable rhythm, your chance of 30-day survival is about 1%. If you don't have a shockable rhythm at presentation, your chance of surviving with a good neural outcome, which is what we're looking for, is a nice round number, or close to a round number. So if you have to do CPR for more than 30 minutes, your chances of survival is really, really rare.
Well, Ken, in addition to being just absolutely, completely wrong, and Canadian.
Sorry, eh?
Sorry to hit you in the p-value there, buddy.
Oh.
So although there have been 5 randomized clinical trials that have looked at patient-oriented outcomes, ROSC, survival with good neurologic outcome, and people will say that, yes, industry-sponsored, and there was no improvement in any of those outcomes, as you call poo. It's real easy when you're a skeptic to poo-poo every study. Those studies also didn't show any worsening of those outcomes when you pull them together. And to me, that doesn't mean lack of superiority. It means that we maybe have some equivalence here, depending on where you work at.
Oh, clearly he doesn't understand the term equivalence from an EBM standpoint, because there's superiority trials, equivalence trials, and non-inferiority trials. And the 95% confidence interval was not within that inferior or equivalence 95% confidence interval.
Sometimes, Ken, statistics don't answer the question. If you remember the rules at the beginning, some of it is clinical judgment and some of it is patient values. And you did a very nice, eloquent job going through statistics and throwing that at the audience. What I would tell you, though, that there are some settings, for example, pre-hospital, rural ERs, where we simply don't have the man or woman power to sustain high-quality CPR, which we know is one of the primary things that we need to do for these patients to improve their chances of survival with good neurologic outcome.
I think he's trying to rural-splain to me. How many shifts have you done in a rural emergency department? Oh, that's right, none. You know how many shifts I've done? I've worked in a rural emergency department for 22 years.
Ken, you may not know this, but I do work in a rural ER now.
Yeah,
for the last 2 years.
Rural. It means 100,000 people plus a CT scanner. Try working without a CT scanner.
Here's the second thing.
One nurse, one doc, no labs after 7 o'clock at night.
Next, he's going to start apologizing for me because he's Canadian. So the second thing is, what about our pre-hospital colleagues and safety in the back of a moving vehicle? I know what you're going to say. You're going to say, well, maybe we could do something cheaper like harnesses or something like that. But show me a study that shows that those harnesses are as good or better, can maintain that high-quality CPR, and still improve survival with good neurologic outcome. It doesn't exist. That study doesn't exist that shows that outcome.
So the burden of proof is on you, though, and you're bringing the mechanical CPR provides a patient-oriented outcome that's superior, and that hasn't been demonstrated with mechanical CPR. I'm not claiming that harnesses would be superior. I'm saying why spend $30,000 on every single truck having one of these mechanical CPRs when you could do a study that shows harnesses versus mechanical CPR for paramedic safety, because that's very, very important. But at the end of the day, who survives?
That's the end of round one. I think our best conclusion there is buyer beware. Recognize that you're spending money on a device that doesn't.
Oh, maple syrup, eh?
Yeah, it comes.
Skeptic, 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 skeptic.
All right, settle down, settle down. Time for round two. This one will get your adrenaline flowing. Epinephrine in cardiac arrest.
All right, Ken, this is over. I mean, do we even need to do this round? I mean, I don't think.
No, we don't. I won.
So epinephrine out of hospital cardiac arrest. So I think we don't know what the optimal dosing of epinephrine is in cardiac arrest. The Paramedic 2 trial did a very nice job of showing us that epinephrine in the current form that we give it in increases ROSC, increases survival to hospital, but at the probability that you're going to have a worsened neurologic outcome. Now, part of the thinking with this is maybe that we're trying to take advantage of the alpha effects of epinephrine, but we're suffering the beta effects. We're having microcirculation issues, increased oxygen demands, post-ROSC dysrhythmias.
If you don't understand what he's talking about, that's hand-waving from physiologic explanations.
So what we're basically doing in the way we're currently using epinephrine is we're saving the heart at the expense of the brain. And the Paramedic 2 trial did a very nice job of explaining that to us.
Oh, saving the heart, yeah. Oh, too bad the brain doesn't work. Yeah, so when it comes to epinephrine for out-of-hospital cardiac arrest, or I'll even expand that to make your target bigger, Sal, show me any study that involves a vasopressor that gives you an important patient-oriented outcome. Reminder, POO, right? There are 4,000 medical publications every day. You're 4,000 behind if you have not read all 4,000, because there's 4,000 on PubMed every day. There's 100 randomized control trials published every day. There's about a dozen systematic reviews published every day. Guess how many have shown that a vasopressor improves a patient-oriented outcome? That's right, Sal, 0. So all you're doing with epinephrine is you're getting an expensive death in the ICU and having a whole bunch of people severely neurologically damaged that do survive. So not a win.
So this is what we do every day, though. We have gaps in knowledge. We don't know exactly what we're supposed to do because the evidence doesn't bear it out for us. And this is where we have to use our clinical judgment and our expertise to fill in those gaps. And to me, this is a gap. The current dosing of epinephrine does not work for patient-oriented outcomes, like you said. So I will concede that. But what I do think makes more sense is a hemodynamic-guided, more linear epinephrine drip. titrated to a diastolic blood pressure of about 35 millimeters of mercury. I know the AHA guidelines have it set a little bit lower. I like to titrate a little bit higher. Now, you're going to tell me there's no evidence for it. You're absolutely right. There's a bunch of pig studies and a couple of case reports in humans.
Did he just call me a pig? You swine.
I did.
He called me, like, we're not even on physiologic hand waving. We're now into a different species to make his argument. Show me a patient-oriented outcome. Do the study with that drip. I mean, it doesn't have to be a false dichotomy, a logical fallacy. What it can be is epinephrine at whatever thing you want to do and nothing. Because Ian Steele, who's a legend of emergency medicine and Canadian, showed in the Opals trial 5% survival out of hospital cardiac arrest with epi, 5% without when they were looking at ACLS versus non-ACLS. You even go to the Aussie study that had the guts to go and do a double-blinded, randomized placebo control trial, showed no superiority with epinephrine. How many times do we have to hit this? Squeezing the vasculature, preventing blood flowing to the brain, the heart, and the kidneys does not seem like a good idea if you want to go with physiologic explanation.
But the beauty of the drip is that you're actually giving smaller doses of the epinephrine, and you're doing it in a linear titration.
Prove it.
We had the guy, one of the co-chairs of ILCOR, sit up here and say, it's not in the guidelines, but I'm doing this too.
Eminence-based medicine.
Oh, it's eminence-based.
You know the
okay.
AHA guidelines, less than 10% of them are level A. And if you look at how many survive 10 years from now, show up in the next guidelines or are reversed or not even mentioned, the number will astound you. Don't throw me the AHA guidelines.
All right, I think that round had to go to points. I think.
Could I get a shot of the maple, please?
It's good. Yeah,
The throat's getting a little harsh.
we don't know how to give it. We just don't know if it helps patient-important outcomes. All right, you ready for round 3?
I'm ready.
Ben, you're mapled up. Round 3 is coming. This one might leave you speechless or maybe even a little aphasic. Should we be using stroke ambulances? Take it away.
Oh, that maple syrup was sweet and smooth. What I didn't tell you is that it's maple whiskey. All right, so I don't want to ignore this side of the audience. We're going to be talking about stroke ambulances. So basically, the third round is a knockout round, because who could argue for stroke ambulances? Sal, you know how much stroke ambulances cost?
Tell me, Ken.
$1 million a year. I didn't go to Evil Medical School for 6 years to be called Mr. Thank you very much. So $1 million to buy one, $1 million to operate it. Do you know how much a non-stroke ambulance costs?
I assume you're going to tell us, Ken.
Yeah, so you didn't do your homework is what you said. Okay, $200,000 a year to run and $200,000 a year to cost. And what do you get? What value, what return on investment do you get for spending $1 million on a stroke ambulance? Zero improvement in a patient-oriented outcome. No superiority for stroke outcome. There is not one study that shows an improved poo.
Shit.
I'm crapping all over them.
So can I just go on record and say that stroke ambulances are crazy? I can just see everybody tweeting right now, he's advocating for stroke ambulances. That's actually not what I think. But I do think it's important for the point of debate is when you have a strong opinion one way, it's important to look at some of the counter arguments for. And so that's what I'm actually going to be doing. And there's really only 2 that I was able to find for stroke ambulances, because otherwise, I agree with you.
Give me the 1-2 punch.
These things are waste of money.
Right here.
So the first thing is that when you look at the stroke literature, and we're not going to get into the whole TPA debate, that's a whole nother session on its own. But when you look at what patients actually show up to the ERs, they're showing up in the outside 90-minute window. So there's a paucity of patients that are showing up in that 0 to 90-minute window. And the reason I'm emphasizing this is that in that shortened time period, it is very biologically plausible that you have softer clot because you haven't had time for fibrin cross deposition. So if you have softer clot, there is potential that if you're getting to these people earlier and you lyse them, you're
See
more
how he's
likely to
hiding
have
in the
good
corner with all
neurologic
these
outcomes.
soft arguments? He's hiding in the corner.
I think I already said that I conceded this
He's
round.
running away. Soft clots. Really? Soft clots? You have to believe the hypothesis that time is brain. And I don't think that burden of proof is met. He has the burden of proof to show time is brain. You know, in the STEMI literature, when they started ramping up and making sure that you got them to the cath lab quickly, guess what happened? More people went to the cath lab who were false positive. 1/3 of strokes turn out to be stroke mimics, largely TIAs, but stroke mimics. You ramp up that system, and what do? You get TIAs through the system quicker and quicker. That felt a little bit like Elvis, by the way. You get them quicker and quicker and quicker. So you're going to ramp up your false positives, and guess what? If you thrombolyze TIAs, the stroke advocates will go, well, they do very well. Only 1% to 2% of them bleed in your brain. You don't have the disease. Are you going to take a 1% to 2% intracranial hemorrhage risk when you don't even have the disease? Don't do stroke ambulances, people.
So the second argument I came up with, ding, agreed.
The second argument is, I'm waiting.
So the second argument I came up with is what we do pre-hospital matters. And triaging these stroke patients appropriately with a CT scanner could potentially divert them to a facility that they should actually be at, as opposed to the nearest facility. So this has actually been proven that if you triage a stroke patient to a stroke facility where they have perfusion-based studies, endovascular therapy, stroke rehab, their neurologic outcomes and their mortality are actually improved, as opposed to going to the nearest ER that doesn't have those capabilities and doing a secondary transfer.
Okay, I will concede that the literature for thrombectomy is much better. I will concede that point. But look at the denominator neglect. How many people do you have to capture that qualify for TPA and stroke? It's in the single digits. How many of those qualify with a large anterior stroke with a salvageable penumbrum? Again, a single digit. And how many of those go on in 90 days to have a good neurologic outcome? Oh, the NNT looks good, 1 in 5. How many billions of dollars did you spend to help those few people? And my question is, could that money be better spent on social determinants of health?
Yeah, maybe something to help grow your beard out a little bit better.
Oh, I won. This is getting ugly. I won the beard growing contest. I think that was below the belt.
Oh, that's definitely p-value. Yeah.
Oh, I got more maple syrup.
How do you advocate for these things?
I think he knows pretty easy. Just no. And we can move on to the next round.
Yep.
Next one, Mike's favorite.
Thank you, sir.
We need a little bit more finesse here, a little bit less brawn. We'll be using Bougie on our first attempt at it.
All right. We got this.
So you should always go Bougie, first of all. So when you look at critically ill patients and you want to intubate them, first pass success is actually a very important outcome. And we know that if you don't succeed in first pass success in critically ill patients, you have increased morbidity and mortality, which hopefully you agree is a patient-oriented outcome.
Yeah, so just get the tube on your first pass, Sal.
If you look at the literature, unfortunately, depending on where you look, I don't want to throw anybody under the bus or any particular environment in, but the range is 60 to about 85% first pass success rate, and I think we can do better than that. And there were 2 studies that have been published in the last couple of years looking at a Bougie first intubation. And what was amazing about those studies is these weren't just simple airways. These were airways that had difficult airway characteristics. And when you look at their first pass success rate, it was greater than 95%, some of the highest numbers we've ever seen.
Yeah, oh, you mean on a retrospective, single-center, observational study where 80% of the people got a Bougie first? You think that's going to change my practice? Really? I mean, it's called the ABCs. We'll go through the alphabet later, okay? ABCs. We control the airway. You guys are experts at the airway, right? If you're in critical care or you're in emergency medicine or you're in pre-hospital, you own the airway. And it is the most Canadian of letters, eh? And so you have... You got that one? You have to have
Unfortunately.
the A. And there, you know, I'll throw literature at you. There's Brown et al., Annals of Emergency Medicine, showed that esophageal intubations was only 3%. We got endotracheal tube interventions 99% of the time plus. So we get the airway, we own the airway, this shouldn't be a problem. If you want to use a bougie, fine, use a bougie. I'm not against using a bougie, I'm just saying don't mandate everybody else to be using a bougie. Because you know what? I have not missed an airway in 22 years.
That's great. Just to correct you real quick, one of those studies was a retrospective observational. The other one was a prospective randomized clinical trial, the BEAM trial. So just if you're going to throw evidence at the audience,
with residents?
just make sure
With
your
residents?
facts are correct.
Were they attending physicians or were they residents? And I'm not dishing residents, I'm saying it depends.
So the second thing is we worry about apnea time, right? Because
I don't.
the longer it takes.
I worry about getting the airway and neurologic outcome. And if I've got the airway and a good neurologic outcome, I don't care if look at the statistical significance. And this is me waving my tuchus at you. Ooh, it was 25 seconds versus 23 seconds. That p-value was less than 0.05. I'm not done. I could do
Are you
it this
done?
way.
Are you done? This is eminence.
Oh, you should see the boxer shorts I'm wearing.
Listen, let me tell you all
You want
something
to tell
real
him that
quick.
story?
Can I tell
Yeah,
him?
you tell him
so
that
he's
story.
got Canadian
I was
boxer
mortified.
briefs on, but they're from American Eagle.
Yeah, and I only... It's like, damn you Americans. And it made in China, probably. You got anything else?
Just the apnea time is quick, man. We don't have to worry about one taking longer, one taking shorter. If you look at the randomized clinical trial, it was 36
mean the one?
seconds. In the one study, it was about average of 36 seconds, whether you did bougie first or you did stylet and endotracheal
So is that a
tube.
clinical outcome?
So I think it matters, yeah. The longer
Oh, how did it
patients-
matter to the patient? Did you ask them? No, they were being intubated.
Right, but the longer they're apneic, the more likely they're going to become hypoxemic.
So yes, they'll become hypoxemic. So prove that being hypoxemic actually has a neurologic outcome. Just like I said in this previous round about strokes, they changed the definition of a TIA to include neuroimaging, a disease-oriented outcome. Resolution within 24 hours was the original definition of a TIA, yet people would have small lacunar infarcts. And now we changed the definition. Ooh, there's people in this audience with lacunar infarcts. It doesn't matter. It has to be patient-oriented.
Hey, bell, time's
Bell.
over.
Yeah, I'll ring your bell.
I'm not sure anything got into the ad hominem tax.
No.
Easy clinical takeaway, I guess.
Yeah, I think we
let's
need a
do it.
take-home message.
Yeah.
So for this round, get really good at one technique, have a couple backup techniques, and always be ready to cut the neck.
Yeah. And I want to say that Sal and I, we know each other well. I would say we're the best of friends.
Yeah, I
And
agree with
so
that.
even though we may come out here swinging punches, we have one main thing.
And the winner is, unfortunately, you got a Canadian ref. The winner is, boys,
Oh.
everybody. The patient wins when we get involved in evidence-based medicine.
There's going to be no rematch.
Yeah.
No rematch.
No rematch, it's done.
Evidence-based medicine should never dictate our care. It should rather guide our care.